So today we have a special guest in Deepti Gurdasani from the UK. She's an expert, an epidemiologist, an expert on everything COVID, as far as I can see. And I've been following her for quite some time on Twitter and other places. And we're very pleased to have you here with us today, Deepti. Johanna Höög and I are going to have a discussion with Deepti about COVID, looking at the worldview, comparing Sweden and the United Kingdom, and focus a lot on the issues of children in the COVID pandemic. Johanna, do you want to say anything?
No, just that I'm so happy that Deepti is with us today, and that I'm looking forward to our conversation.
Okay. Thank you for having me.
I think the first thing that we want to talk about is to have a discussion on what's happening in the UK and around the world at the moment, and to see if we can contrast this to Sweden. And I think at some point Johanna has a couple of slides to throw in here. But it would be really nice to discuss that, and also I think add in, and where we might focus some on some vaccinated or mostly vaccinated countries, and then some non-vaccinated countries in the sort of tale of two pandemics, contrasting perhaps the UK, Israel, and the US with South Africa, Australia, Vietnam right now. What do you think of this, and what do you think the future will be, Deepti?
So what we're seeing in the UK and in many parts of the world right now, including areas that are highly vaccinated, so the UK, Israel, and the US, is essentially a surge in the pandemic. So we're in the middle of our third wave in the UK right now, which seems to be linked to the Delta variant, which we know is highly transmissible, possibly more severe, and more able to escape vaccines. We've sort of, rather than containing it, continued to open up in the middle of a surge. But we're seeing the spread of the Delta variant now across the globe. It looks like it's going to be the next dominant variant and has been linked to spread in much of Southeast Asia, including in elimination zones or former elimination zones like Vietnam and Taiwan, and is also causing what appears to be massive surges in South Africa and other parts of the world that have very little access to vaccination. We're also seeing this in Israel, which was doing really, really well until recently, until it seemed to have imported the Delta variant, which has now been associated with community transmission. And they've taken urgent action to try and contain it by reintroducing masking mandates and pushing to actually vaccinate adolescents who seem to be associated with a lot of spread happening of the Delta variant in the areas that we've seen this. So, for example, in the UK, the primary age groups that appear to be affected are secondary school children and young adults, and the infection rates in those are above 1,000 per 100,000. So it seems to be those groups that are largely driving the pandemic in the UK. And it's very clear the Delta variant actually spread first within school environments and then back into the community. Israel seems to have realized the importance of schools in Delta transmission, as did Singapore, and has taken strong steps to try and address this.
Can I ask you there, Deepti, because I've been really interested in this spread in schools, and my feeling is that it's always been spreading in schools. It's just that we're seeing it clearly now with the Delta variant because the older population is vaccinated. Would you agree with that, or do you interpret it like Delta is actually spreading better amongst children?
I think to an extent, I don't think it's as clear-cut as that. So certainly I agree with you. Schools have been a major area of spread. There's so many studies from the first wave that actually show us that one of the most effective interventions in bringing down R, or reproduction number, which is essentially the rate of growth of the pandemic, was school closure. And with school openings, cases always rose in different parts of the world. But we did see when the Alpha variant, which is the so-called Kent or UK variant, arose, in sort of November, December of last year, we saw that even at the same point in time, there was a disproportionate increase in cases of school-age children of the Alpha variant compared to the previous variant and compared to other age groups. So it became dominant first in children even compared to the previous variant. So it does seem like there was a sort of, I don't know whether it's a predisposition. It may not be a susceptibility issue. It might be an environment issue, because it might be that, it spreads better in schools. We don't know why exactly, but it was disproportionately common in school-age children compared to other age groups. In recent studies from Scotland, we've seen the same pattern with the Delta variant. So we've seen, for example, 5 to 9-year-olds, again, this variant was disproportionately common at the same point in time compared to the previous Alpha variant, compared to other age groups. And again, why that is, we don't know. It may not be a biological or susceptibility issue, but some sort of interaction with the environments in schools that make them even more susceptible to more transmissible variants than, for example, the environments that adults move around in. So we don't know exactly why, but there has been a disproportionate impact on children. But of course, we know that this variant is highly transmissible, more transmissible than previous variants across all age groups. But why we're seeing this particular spread in school-age children is still quite unclear.
Yeah, although there's more hospitalizations of school-age children now than there were with the previous variants. And so that might be part of it too, is because they're becoming more seriously ill, and so we're testing more. Is that a fair statement?
I don't know if we are testing more because more getting hospitalized, because it's still a smaller proportion. It's a small proportion getting hospitalized, but comparing this wave with previous waves, it does seem to be that hospitalizations in the UK at least have risen more rapidly among children. And we've heard reports from the US among pediatricians and people in critical care that they are seeing teenagers who are unvaccinated come in and have severe disease requiring ventilation in a way that they didn't in previous waves. So all of this suggests, and similar reports from India, Singapore as well, suggesting that disease is more severe in young people. We know that this is more severe across all age groups again. So we know that it's about 2 times more likely to cause hospitalization and also more likely to lead to death, for example, from the recent studies from Canada. But again, we don't know whether that level of severity is much greater in children, although it's very clear that pediatricians are raising concerns, particularly in adolescents who aren't vaccinated, about more severe disease. And that's extremely concerning, because that's something we need to really understand, and also highlights the importance of not exposing children to a virus that could potentially cause much more severe disease in them. And it also kind of questions this myth of children not being severely affected by this infection, because clearly there are children who are being severely affected. Hospitalizations in children in the UK are at par with where they were in the second wave.
Yeah. Well,
should I show my graph, Andy?
I think so. I think that's a good point for that.
So what I've done, Deepti, is that I have just started to compare a little bit Sweden and the UK. It's very interesting to us because the UK has taken quite a different approach. First, we followed each other in the beginning, and then you switched and we stayed on this herd immunity approach. And so this is just 2 graphs comparing the death numbers per capita in the 2 countries. And as you can see in the first wave, the UK is here the pink line and Sweden is the green line. And the UK had it slightly worse, but then Sweden really struggled to get down the contagion. And then in the second wave, the UK did quite dramatically worse than Sweden. And the result of that is that the death toll in the UK is now 1,900 deaths per million, and in Sweden it's 1,450. So in the end, the UK has been hit harder than Sweden. I just wanted to hear your thoughts around this, because you did eventually go into a lockdown. Why do you think that it has become so much worse for you?
Well, I mean, I think, the answer is in your question, eventually. Actually, I would argue that the UK has followed a similar strategy to Sweden, because the idea was never to contain infection or the pandemic or maximal suppression of infection. The aim was always to keep hospitals at or just below capacity, with capacity being defined as long as we don't have oxygen shortages and we have beds for people who need urgent care, it's fine. And that unfortunately meant that we were happy with hospitalizations rising to about 4,000 per day, which is very considerable, and our critical care being absolutely full, to the point that people had to prioritize who to give a ventilator to and who to deny ventilation to before the government took any action. And, that is in some ways not very different from a herd immunity strategy, because there is it kind of says that transmission doesn't matter as long as hospitals aren't overwhelmed, which is really concerning. And that's exactly why the UK ended up in a situation where it acted so late that it had over 80,000 deaths related to the second wave and over 150,000 deaths from COVID in total. And I think that's what Sweden has also done. It's consistently not had adequate measures to contain transmission and has always acted at a point in time where it was inevitable and had to act to essentially prevent healthcare systems being overwhelmed. So I think the UK strategy is quite similar to Sweden. What's changed now is we have a high level of vaccination in the UK, which means that the government considers that we can let transmission get much, much higher than we've had at any point before, because once again, the focus was never transmission. It means that, obviously, given our hospitalization rate is now about 6 times lower than it would have been without vaccinations, we can now let cases get 6-fold higher than they were before we lead to hospitals getting overwhelmed. And I think that's what vaccination has meant for government. It hasn't meant containing transmission. It has meant that they can allow cases to get much higher before they act.
So sad to hear.
Yeah, and of course, there's a lot of different factors, but one of them is perhaps population density, where the UK is about 20 times the population density of Sweden. So in Sweden, we've been lucky, even though we've been unlucky. I mean, we have a high rate, but it's not quite as high as it certainly could have been.
Absolutely. Wow. And Sweden, compared to the other Nordic countries, has done terribly. So if you compare like for like, there's absolutely no question that it's performed very badly. I mean, Sweden had many advantages going in that the UK didn't have. The healthcare system is much better than ours. The general welfare support system is much better than ours. Class sizes are smaller. So yes, they may not have had the same they may not have had mitigations, just like the UK didn't. But, they have far fewer people in each classroom compared to the UK. So in many ways, Sweden, is started from a baseline level that is better than the UK. So I don't think it's fair to compare it to the UK. But when you compare it to Nordic countries, it's done really, really badly. And it's very clear that this strategy doesn't work.
Yeah. I'm so happy you said that, because people here constantly compare to the UK. Oh, look at the UK. We're better than they are. It's like I have to constantly say, you don't want to compare to people who have failed. You want to compare to people who have succeeded. But okay.
It's so weird, because in other, for example, in the Olympic Games that, it just started, and there's nobody who ever says, let's compare with the person who came last, right? And all of a sudden in this pandemic, that's what we are told to do. Why should we not look at the people who won, the people who have the least amount of dead, the least amount of sick? It's so sad. But I just wanted to clarify here now then, because in Sweden we get to hear this a lot. Look at the UK, they had lockdowns and they did worse than us. So your explanation of this is that the lockdown came too late. Is that?
Yeah, absolutely. I mean, of course, there's no country that hasn't had lockdowns when their hospital capacity got overwhelmed. That's not pandemic control. I mean, we need to be clear. Lockdowns are not a pandemic strategy for control. Even the WHO has said they should be a measure of last resort. When you have to go into lockdown, it means that your pandemic strategy has failed. It means that you haven't put in the public health systems in place to keep cases down, and you have to then put in severe national restrictions in place because you haven't managed to contain spread until it's gotten to very, very high levels. So let's remember that the countries that have had used lockdown as a primary strategy to control the pandemic essentially never understood the basic public health principles and strategies that were needed to contain the pandemic. You look at Southeast Asia, there are countries that never had to institute national lockdowns because they had excellent surveillance systems. They sometimes had to institute localized restrictions in particular contexts because they knew where cases were coming from, but they never had the sort of national lockdowns that have been used as the only measure to contain the pandemic in countries like the UK and Sweden. So, I don't think you can say that, they instituted lockdowns, but they didn't work. Of course, the lockdowns work. I mean, it's very, very clear. Exponential spread has continued until lockdowns have taken effect. But the fact that lockdowns have been late and that lockdowns have had to be instituted at all means that governments have completely failed to get on top of this.
Well, we really haven't had severe, strict lockdowns. We've only had sort of mild lockdowns or mild, some restrictions limiting groups to 8 and 4 and things like this. But that's another example of how we have acted too late on these, just as the UK. But doing the lockdown didn't really help because it was too late. So it's if you compare the two, where we have had a mild lockdown, you've had a strict ones but too late, and even done worse. It just shows it doesn't work unless you do it early. So, I mean, okay, but can we just go back for a second, because we have, both internationally and in our own countries, we have the big question, okay, and I think the big question now is with we're now seeing out of Israel waning immunity, okay, where we have to worry about, we know winter's bad, we know Delta's bad, we know school opening's bad, okay, so what's going to happen now, okay, where are we going to go with waning immunity, winter, Delta, school reopening? What do you think is going to happen? I mean, I know this is, who knows, its predictions are always questionable, but what do you think?
Well, I think it's a perfect storm. You're going to have opening schools, and we know that Delta spreads very rapidly in this environment unless there are robust mitigations. And the UK, for example, and many countries in Europe don't have robust mitigations in schools. And that means that a spread is likely to coincide at a point in time where immunity is waning in our most vulnerable and elderly people who were vaccinated early on in the pandemic. And that's what the Israeli data suggests, as do laboratory studies on neutralization of Delta with vaccines. And I think unless we actually make active efforts to preempt that, and the only way to do that is by essentially vaccinating adolescents now, before schools reopen, putting in mitigations in schools, because we're going to need them, because not all children can be vaccinated. That means ventilation, masking in schools, like many other countries are doing, reducing class sizes, and giving boosters to those who are vulnerable, who were vaccinated early on, particularly with AstraZeneca. I think unless we do all of those things, I'm really concerned about what's going to happen in winter. I mean, I want to add here that our government strategy to deal with this has been to infect as many children as possible over the summer. And, while schools were open, to try and develop some sort of herd immunity in them. They don't seem to understand, firstly, that exposing children to this novel virus that causes long-term disease is going to leave many children with chronic illness and disability. But they also don't seem to understand that vaccines are a much more safe and effective path to develop immunity, because there's no country and population that's developed herd immunity through natural infection. So, it seems to be a very risky and unethical strategy that they've adopted, because rather than vaccinating children, they've chosen a path to actually expose them to maximal infection in the hope that immunity in them will protect adults over the winter, which seems like a rather ridiculous strategy to adopt.
Yeah, a lot of people argue that this myocarditis is a problem. I'm sure you've seen this chart out of the U.S. where they talk about myocarditis, hope I'm pronouncing that right, in children, which goes up for sure. This is what people point to, but people often misunderstand numbers, because if you compare it to hospitalizations prevented by vaccination, there's a large difference. Okay, I mean, sure, it's better at 65 plus than anywhere else, but it's still considerably better with children. Do you want to comment on that, or?
Yes, absolutely. And it's also the level of severity. So I think the CDC estimated that for 1 million adolescents vaccinated, the risk of myocarditis was about 30 to 40 people or children developing it. But the gains in terms of preventing hospitalizations, ICU admissions, were much greater, as well as, I think for 1 million adolescents vaccinated, they would prevent, I think, 1 death as well. And let's remember that most of these cases of myocarditis are extremely mild. So essentially, you can treat them with, ibuprofen, which is essentially an anti-inflammatory painkiller, so they don't require hospitalization in most cases. So, and let's also remember that this comparison was carried out based on the US exposure risk at the time. which was much lower than it is now and much lower than it is in the UK. So it was carried out for a particular level of cases in adolescents. I can't remember what the actual numbers were, but they are orders of they're like several fold lower than the current rate of infection in the UK, and certainly much lower than the current infection in the US. And as infection rates rise, the benefit risk tilts even more in favor of benefit. So I'm really saddened that even scientists have kind of put out misinformation suggesting that because of the risk of myocarditis, this is somehow not a vaccine that should be given to adolescents, when it's very, very clear that with every medicine, there's a risk versus benefit, and the benefits far outweigh the risks at current rates of infection in all of these areas. So unless you're living in a zero COVID zone, where you might consider the risk benefit, and most of us aren't, it's very, very clear the benefits of vaccinating adolescents. And I'm not even talking about the prevention of long COVID at this point in time, which is very substantial. And also, the prevention of educational disruption, which hasn't been quantified, and the reduction in risk of passing the virus on to clinically vulnerable parents who can get very ill and die. So, and also the overall benefit in terms of reduction in transmission at population level. So none of these are actually looked at here. Here we're literally looking at individual benefit. And even at individual level, it's beneficial. At population level, the benefits accrue even more.
And let me just state a number example, because in Sweden we have a great, not a bad, unfortunate set of numbers that we can present. And of our roughly 2 million children in this country, we have about 600,000 that have been infected, and about 250 of those have had multi-inflammatory syndrome. And what you just said is about 10 myocarditis for a million, so that would put about 6. So you're comparing a number 6 for a relatively mild side effect to 250 for multi-inflammatory syndrome. I think that's pretty close to right.
40 cases of myocarditis, but yeah, I mean
40. Okay, 40.
30, 40.
So if it's 40, that's 24 versus 250. So it's 1/10 the risk of MIS. Yeah.
And that's just one side effect or consequence of having had COVID-19, right? So we also have long COVID. But Andy, if you stop sharing, I thought because Deepti was talking about parents might die. And so in this week now, there was a new article coming out where they estimated how many children have become orphaned by this disease. And all over the world, it was 1.1 million children that have lost a parent or a caregiver. And if they included grandparents, because often in the world, grandparents are really important, both economically and socially to children, then the number was over 1.5 million children that have lost a caregiver. So they also, with this paper, they published an interactive tool that you can go in and check for different countries. So I did go in and check for the United Kingdom and Sweden. And in the United Kingdom, 9,300 children have been orphaned during this time. And in Sweden, the same number is 2,000. So I then went in and checked how many children you have in the UK, so 14.3 million, and in Sweden, 2.1 million in this age category. So the end of it all is that in the UK, 651 children per million have been orphaned. That's quite a high number. But in Sweden, it's even worse. 939 children per million have been orphaned by this disease. So I can't quite understand, because in general in the UK, you've had a higher death toll. But to me, I don't know. Do you think you have any explanations for this, Deepti?
I think it might be the age demographic. I mean, isn't the population pyramid of Sweden sort of more weighted towards older people, which may mean that there are more people who are sort of grandparents and caregivers who've sadly passed away compared to the UK. So I think it might just be a kind of weighting of the population, because I think the life expectancy in Sweden at least was higher. I don't know about it anymore after the COVID pandemic. And of course, many people will argue that, a lot of this doesn't have to do with infection spread in children, but it's almost definite that at least some of those infections were passed from children onto caregivers, because there are very large data sets now in the US, from Denmark, from the UK, looking at millions of people, that actually show that parents of children are at higher risk of infection. And data from the UK shows that parents of children are also at higher risk of hospitalization from COVID. So, compared to, people who are matched in the same age group who don't have children or don't have children going into in-person school. And that's really, really concerning because, we also know from these studies that you can reduce the risk for parents and caregivers to near baseline for the population if you actually put robust mitigation in classrooms, multi-layered mitigation in classrooms. But we haven't protected children, and sadly, we have also haven't protected their parents and caregivers. And we never talk about the impact of that, the impact of children losing caregivers because they are at higher risk. And it's good to see that people are quantifying this and considering it now, because it has a huge impact on children, this sort of early bereavement. And people constantly talk about the mental health impact of school closures, which I do agree with. But they never talk about the impact of bereavement. And the only way to mitigate all of this is to make our schools safer, which many countries still aren't doing and aren't prioritizing.
I'm willing to bet that the average age of parents in Sweden is higher than the UK too. And maybe that's what you were alluding to. But what do you think of this? We're talking about mitigations in school. And I mean, let me say this delicately, a lot of pediatricians even are sort of arguing against mitigations like masks in both Sweden and the UK. To me, it's maddening. Okay, but the Swedish Pediatric Association, however you translate it, has come out more or less against masks, if I understand it right. But the American Pediatrics Academy just this week announced that they think children above 2 years old, or 2 and up, I think, should wear masks to school. Can you comment on that?
Yeah, and that's what the CDC has been recommending for a long time, that children 2 and up wear masks in schools. And the CDC has now done a lot of research that has shown that masks are protective in schools, as are HEPA filters and ventilation. And there are studies from around the world that show multi-layered mitigations within classrooms reduce transmission in schools and risk back into parents, communities, and for teachers. So I'm really saddened by the fact that other countries are not taking this seriously. I mean, I think we've all heard about New York, where the government has essentially promised to install 2 HEPA filters in each classroom. I mean, we know of schools where parents can actually monitor the carbon dioxide levels in their children's classrooms because there are apps and they know that their children are in a safer environment. Whereas in many other countries, like the UK, we have 30 children crowded into classrooms with no ventilation, no social distancing, no masks. And I'm very sad to say that a lot of scientists and the many members of the pediatrics community have supported the idea that 1, children don't get severe disease, which is not true. And 2, we don't need safety measures for children because they don't develop severe disease, which is also not true. I mean, at the very least, they should be able to see the level of educational disruption and the risk to parents of children, which is very, very clear from epidemiological studies. Yeah. And of course, a very real risk of long COVID that affects 7 to 8% of children infected, lasting for 12 weeks or more. And sadly, many of those children continue to have symptoms after 1 year. So this is not some sort of mild post-virus syndrome, as it's being called. In fact, I don't think many post-viral syndromes are mild, but that sort of statement has been used to seriously minimize the risk from an infection that we know is a multi-system infection that affects every organ in the body, including the brain in adults, even in young adults with mild symptoms. And just because we haven't done equivalent studies in children doesn't mean that their brains and their organs are not being impacted long-term. And we've argued about the long-term impacts of vaccination, which are theoretical and unknown, whereas we're not doing anything about the real risks of long COVID, many of which are known, and the ones that are unknown are seriously concerning already.
Yeah. I actually have a question to you from a mother with children that has long COVID. Actually, I have many questions also from myself, but one question I have from her is, have you in the UK seen any links between having long COVID and autoimmune diseases?
Yes, I mean, there is a lot of research ongoing in this area, and it's not that clear cut, but it does seem that SARS-CoV-2 does induce the development of a lot of autoantibodies, by which I mean it leads to this sort of reaction where it creates antibodies that attack our body's tissues. And the study that I think was published in Nature or Nature Medicine actually showed that the level of these antibodies can be quite similar to autoimmune diseases, serious autoimmune diseases like SLE, for example. And we don't know how long these persist, but it's certainly one of the hypotheses around long COVID. And we're having research done in the UK right now that is trying to look at these sort of antibodies as markers of long COVID to try and sort of predict or find biological markers that show what's going on in the bodies of people with long COVID. So this may well be an autoimmune inflammatory disease. It's unlikely to be one single syndrome. I think it's very likely that it's a combination of different things in different people. But for some people, certainly it looks like an autoimmune etiology is possible. And that really also brings into question all these people who keep saying, this is psychological, it's in your head, and all those, I guess researchers who are looking to treat it with sort of counseling and other methods like that, when it's very clearly a complex biological disease that we don't understand yet. And just because we don't understand doesn't mean that it doesn't have a complex multifactorial and multi-system etiology that we do need to understand and learn how to treat. And unless we actively research this area, we're not going to understand why these people are suffering. And we have millions of people suffering across the globe. I mean, in the UK alone, we've had 2 million people develop long COVID. So essentially, we now have a whole generation of people with long-term symptoms that we don't really understand or know how to treat, but we seem to be happy to create millions more through the strategies that many countries are following when they talk about living with the virus.
So there's another question there for me, because it seems to me that in the UK you have so good handle of the situation in the sense that you know how many have long COVID. In Sweden, we mostly just refer to the numbers that you have provided from the UK and a few other countries. But how do you have such good information about? Because here, I think we have had 200 children that has been diagnosed with long COVID. But if we look at your numbers, it should be thousands.
I mean, so we're very good in the UK with our surveillance research. So we're very good at monitoring and seeing what's happening, but very poor at actually intervening and preventing it. So, we are actually surveilling and watching a car crash in motion, but doing nothing to prevent it. What we have here is the Office for National Statistics, which runs a survey every week on 100,000 or more than 100,000 people, follows them up, and carries out essentially testing in households on these people across the nation. It means that we have very accurate idea of infection and changes in infection every week. And that's very important because this doesn't depend on testing, whether people come forward for testing. And for children, it's particularly important because it doesn't depend on whether they have symptoms or not. So it means that we are picking up asymptomatic infection. And when you compare this general survey that does not depend on symptoms and just randomly tests our population, we see, for example, that surveys that depend on symptom-based testing on children are very, very biased and hugely underestimate rates in children. And because we have this and we are able to then follow up those who are positive and negative for infection longer term to see what symptoms they have, not only do we have very good quantification of those with any type of infection, be it mild, asymptomatic, and how often they develop long COVID, but we also have control groups to show us that this is related to infection. This is not something that's baseline in the population because of pandemic fatigue or mental illness due to restrictions of the pandemic, which many people try to dismiss, with long COVID. We know that those people who are positive are 8 times more likely to have persistent symptoms than people in the general population who are negative. So we know that this is a real disease. And we know that it happens even in those with mild symptoms, including in children.
And the same people who argue that long COVID is probably psychosomatic in some ways or something will argue that masks don't work despite the firm evidence that they do and that they don't harm you when you wear them. And yet they'll say, if I put on a mask, I can't breathe in 20 minutes. It's pretty amazing contrast. I'm sorry.
Yeah, I mean, what I've learned through this is you can't deal with ideology with facts. I mean, there are scientists as well. and medics who are not interested in facts, and they are interested only in ideology. And I think that's what's really made it very hard to influence policy, because it looks like the scientific community is divided, but the scientific community is also, some members of the scientific community also have ideological biases, and they are not acting on the evidence, sadly, and they're not acting in the interest of public health.
Yeah. We have Association of Pediatricians here in Sweden that have decided to go out with the fact that they are not condemning Great Barrington Declaration. So by not condemning them, we say that, well, then you have already taken a stand in the question. And also they have gone out and said, we do not recommend vaccinations for children under 16. What do you think about that?
I think that's very similar to the situation in the UK. So our body, the JCVI, which is our committee of scientists, actually primarily pediatricians, who decide who gets vaccinated and whether adolescents get vaccinated or not. A member of them is actually a signatory of the Great Barrington Declaration and has very openly said that it's better for children to get infected than vaccinated and develop immunity through natural infection. So he's very much been a proponent of.
But he just went off, right?
He said he is going off soon. Yes.
Okay.
It looks like he is leaving the committee now, but he was on the committee when the decision was made, and he very publicly said that he feels it's better for children to get infected than vaccinated. And our committee, that includes many people like him and others who've said that children don't get seriously ill and don't suffer from the impacts of COVID, have made a decision not to go ahead and vaccinate adolescents, except those, not even those who are clinically vulnerable, but those with very, very specific disorders. And for us, it's not even above 16s who will get vaccinated. Only those whose birthday is a few months from 18 will get vaccinated. So for our population, it's only above 18s who've been vaccinated, and the vaccinations will not be offered even to 16 to 18-year-olds.
Yeah,
so, I think they're all reading from the same book, and it's all a book of pseudoscience and ideology that has absolutely no semblance to the evidence, which is extremely clear on this, as the CDC has shown. And unfortunately, none of these bodies have actually quantified the risks or benefits. They're very happy to talk about the risk of myocarditis, but paracetamol has a risk of liver damage, but people take it because the benefits outweigh the risks. And unless you actually quantify the benefits and the risk, you can't say anything about whether to recommend a drug or a vaccine in a group or not. And sadly, a lot of these agencies have gone for vague, non-specific concerns about side effects without actually articulating what the benefits are.
I would want to ask you, Deepti, first you closed schools in the UK, right? And then when you opened the schools again, what did you do to prevent spread in schools?
Nothing. So effectively, schools have been closed to contain transmission. And totally, I think we've had over 4 months that kids have been off school. But right up to the point schools were closed, the narrative was always schools are safe and children don't contribute to transmission. And right up to the day they were closed, that was a narrative. And on the day that they were closed, our Prime Minister stood up and said schools are vectors of transmission and they need to be closed. But even during that long period of closure, there was no attempt made to actually put mitigations in place so that when they opened again, we wouldn't need to close them. And of course, you may know that in the last week, at the end of term, this time, we had over 1 million children off school for COVID-related reasons. Not all of them were infected, but many of them were isolating because they were contacts of cases who were infected. So we've had mass educational disruption, not just school closures, but school absenteeism, which has, of course, impacted disadvantaged communities more, because we know that absenteeism has been higher in particular areas of England. And our government has absolutely done nothing to prevent this. They keep saying that they're prioritizing school openings and that they're prioritizing the welfare of children. But essentially, it's their actions that lead to school closures. Because if we were able to make schools safer, then children could continue learning in person without these levels of educational disruption. But bizarrely, it's the people who deny that transmission happens in schools, which there is no doubt that it does, who have and talk about the mental health harms of school closures are exactly the people whose rhetoric has directly led us into school closures because we haven't managed to make schools safe. And scientists who have worked very hard to push for mitigations in schools are labeled as pro-school closure, when actually if we had been listened to, schools would have to been able to remain open without children being affected so much.
There's one thing more about schools that is quite telling about the UK and Sweden.
Oh gosh,
So
yes, of course.
there is this program called Explore that both Sweden and UK schools are doing. It's more widespread in Sweden, but this has been done before the pandemic, and it was also done during the pandemic. And what Explore does, it's the artificial intelligence, and they look at the children's eyes at the same time as they're reading a text, and then they can estimate how well the child is reading, where it gets stuck, what things that they have issues with, and so on. And what they did was that they compared how well children in Sweden and in the UK read before the pandemic and now after the pandemic. So in the UK, 147 schools participated. In Sweden, that was 247. In the UK, 9,000 students were tested, and in Sweden, 67,000. But what was really surprising in this was that in both countries, the reading ability of children has gone down with the pandemic. But in the UK, it had been reduced by 5.2%. But in Sweden, it was reduced by 10%. And this is where schools have been open the entire time. This is the equivalent of...
I just want to kick in and say this is primary schools.
Yes.
Those schools have been open the whole time, because people will argue that they went online for the high schools, some of the secondary schools, but this is primary school students.
Yeah. So in the UK, we have a delay of 4 months in reading development, whereas in Sweden, the same age category has a delay of 7 to 8 months. So this is, of course, quite shocking to us, because one of the mantras that we've heard here is that it's so good for children to be able to attend school, and it would be harmful for their education to not keep schools open. But this actually shows that keeping schools open and having a high degree of societal spread of COVID-19 has really been harmful for the education of children, because what this report is saying is that there has been so many sick days. Teachers have been sick, students have been sick. And that's also what you said earlier, right? That there is such a high absence from school in the UK. It must make an impact also, right?
Absolutely. I think absenteeism makes a huge impact also because, when I think during periods of remote learning, the whole system is skewed towards remote learning, whereas when you're absent, you're just kind of out of class, although there might be remote learning available. And I think the impact, and one of the things that the study, I don't know if they looked at, but what the impact is always worse for particular communities. So it's particularly worse for disadvantaged groups, for poorer communities. And for example, children of parents who are frontline workers who may not be able to essentially put in the time to sort of catch up with what's happening. And sadly, countries haven't really addressed that. So they haven't addressed catching up, particularly in disadvantaged communities. In the UK, for example, support for remote learning was very, very late in terms of providing laptops, which many families didn't have to support learning. So again, for governments that say that they're prioritizing school openings, they seem to be prioritizing school openings without mitigation, without support for children, and without support for adequate remote learning when children do have to isolate, and also support for the mental health of children who have suffered from early bereavement. Many have long COVID. And I think without that, we are badly letting our children down. And I don't think governments have the right to say that they care if their actions don't reflect it.
So what would you recommend for schools? What would be the most important mitigations for schools?
I think dealing with aerosol transmission. I mean, I think wiping down chairs and giving hand sanitizer is not the major solution, which is unfortunately what most schools are doing right now. So I mean, not just opening windows and doors, actually having air filtration devices and carbon dioxide monitors to maintain carbon dioxide levels low and at a safe level, and to absorb all the aerosols and reduce the level of infected aerosols in the air. mask use, because multi-layered mitigations matter. One is not sufficient. So mask use in primary and secondary schools, not just in secondary schools, reducing class sizes to allow a level of social distancing. All of those things, I think, are the ones that will make the biggest difference more than anything else, because those are the things that deal with the way this virus transmits, which is through aerosol transmission. I would definitely prioritize these over things like hand sanitization, hand cleaning, which are good to do, I think, in general, but not really addressing the nature of transmission of this virus.
And here in Sweden, if you have a child in school, you can demand by law that they provide a risk assessment. And you can ask for a risk assessment on ventilation and filtering. I did it. Okay, and they had to come back to me for my 9-year-old. And so you can do that. And you can also offer to buy these HEPA filter portable units. Okay, yeah. I just bought 2 of them for my daughter's preschool. She will start in August, maybe, depending on the infection. And the headmaster of the preschool was delighted that I was happy to do this. So I would encourage parents to do this.
Because
Step forward and do it.
I tried to do that for my daughter's classroom, and I was told that they wouldn't accept it unless we provided them for the whole school, which of course was too expensive, because, I mean, I think it makes sense. They felt it would be unequal, but it's much harder to source HEPA filters for an entire school.
No, but it is, but it's not. You know what I did is, I tried this for my daughter's primary school, my 9-year-old, and I was refused without a reason. But I had other parents willing. And so what I was willing to do was to set up a network where a parent group of parents in each classroom bought one of these.
Oh, I see.
And many of them were interested in doing this. And it didn't go anywhere. But the headmaster insisted that they have installed HEPA filters in their general ventilation, which I don't know exactly what that means. But that school has been pretty good this last year at small numbers of breakouts. So, but my 9-year-old was the only child who regularly wore, every single day of last year in school, wore a mask to school. Loves them. In Sweden, in the winter, she says it's fantastic. Keeps her face warm. She wears them outside. So this is, but you, there are things you can do. I'm happy you said all those things, Deepti. I hope people will take notice, and I hope what we need though is more than us pushing the government. Is we need community action. If we can't get people on board, and more here seem to be, slowly, but more seem to be getting on board, although it's gone down in summer. But if you don't have community action, you'll never force this issue.
I mean, the thing is, there is a lot you can achieve with community action. I think it's extremely powerful. The difficulty is when it comes to things like policy, for example, on vaccines, which I think many parents feel powerless. I think many parents of adolescents who want to protect them and who would have been able to protect their kids did they live in another country, are not able to. And I think with all those mitigations, I would also add vaccination of adolescents before school reopening. I think it's very, very important to protect them. And the US has, for example, vaccinated more than 9 million under 18. So the idea that we don't have enough data on safety of vaccines over this period in time is ludicrous. It's clearly effective and safe, and we should be acting to protect our adolescents from essentially very high risk of exposure in many countries right now. In the UK, it's very, very clear that if you're not going to get vaccinated, you're going to get infected, because the plan is essentially that the majority of the population gets infected before winter. So it's not even a sort of decision between the risk of exposure and risk of getting infected and vaccination. It's actually a clear sort of, the choice you have is your child gets infected or vaccinated, but sadly you don't even have that choice because you haven't been given that choice.
If the data out of Israel is correct, this will all change. They'll have to change. So, okay.
Yeah, but it's just about how many millions of children will get infected and develop long COVID before they change. And I think
before they change, yeah.
Exactly. I mean, the rates here for children are above 1,000 per 100,000. And that tells you how many children are getting infected every day when they could be protected by vaccination.
Well, in the U.S., when I was in the United States, we used to always say that in order to get a traffic light at an intersection, you had to have somebody die first. And I'm afraid this is what we're aiming at. I think this is the problem. And I think we have some serious issues with risk assessment when you think you're safe versus when and looking forward. Anyway.
Yeah, the Lancet study that came out, I think, yesterday, which included under 16s. And this study on a cohort of 80,000 people assessed in terms of cognitive ability by questionnaire shows a reduction in cognition, even in those with mild infection. I mean, of course, the level of reduction correlates with the severity of infection. So people who are admitted to ICU and hospitals, of course, have much higher levels. But even people who had mild infection have a level of reduction in cognition over time. And for those hospitalized and requiring ICU care, the level of reduction was comparable to somebody who's had a stroke. And this is a sort of virus that we're happy to expose our young people to. And I don't understand the logic of that.
Sorry.
Yeah.
You go, Andy.
Well, as a neuroscientist, I mean, that correlates perfectly well with the loss of gray matter that was shown out of the Oxford study, and is probably the single scariest thing outside of death that I've seen from COVID so far.
Absolutely. I mean, there's accumulating evidence that SARS-CoV-2 may be related to neurodegeneration. I mean, we're seeing young onset Parkinson's in people following acute infection. Yeah. We've seen thinning of brains, even in young people post-COVID, thinning of gray matter in particular regions of the brain that are also associated with symptoms like, loss of taste, loss of smell, memory problems. And, there are those animal studies that we know of where, monkeys were infected with SARS-CoV-2 and they developed Lewy bodies in the brain. And all of this evidence is being ignored. We know that children develop long-term cognitive symptoms, brain fog, poor concentration, poor memory. And we know that these are the symptoms that are likely to persist. Other long COVID symptoms tend to reduce over time, but neurological symptoms tend to become more common, persist over time. And it's very, very likely we're dealing with a disease that causes a level of neurodegeneration, even in young people, but we are ignoring all the evidence on this.
Yeah. It's dreadful. But I normally study sperm cells in my normal research. And I have reflected over that the receptor that SARS-CoV-2 binds to is most expressed in testes. And there are some studies that show that men are less fertile after they've had COVID-19 infection. What I'm really afraid of is that we don't really know what happens with young children that have been infected. Maybe, I don't know if there is a particular age, for example, puberty, if you have an infection during that time, what will happen to the fertility of our whole future generation? I'm not saying that we know, I'm just saying that we don't know. And therefore we should not expose children to a virus where we don't know the long-term effects. So now we are finding out more and more what can happen to our bodies when we expose. And even rare things become quite common when you infect enough people with a virus like this. I don't know, have you heard anything about fertility issues, Deepti?
I mean, I have heard it, but I can definitely say it's not my area of research, so I probably shouldn't comment on it at all.
No, I think this is something, though, that really, I mean, this is not something we can know now, right? We can only find out maybe first 10, 15 years in the future.
That's the thing, even neurological impacts. I mean, if you look at measles and polio, the long-term neurological impacts were understood maybe decades later. And what we have with SARS-CoV-2 is we're already seeing them. We're seeing them so early on. There might be other impacts years down the line that we don't even know about. But the fact that we're already seeing them and they're so common should be hugely concerning, because so many viruses impact our brains much later in life. And, a precautionary principle here, please, for young people when you don't know what this virus does, particularly when the data we're seeing is already so worrying.
Agreed. Yeah.
What do you think about, what are your thoughts about how, in a general way, COVID threatens countries that are working to do zero COVID and struggling to keep the infection out? I mean, maybe mitigation versus suppression, and what is the countries that are doing mitigation, how are we affecting those that are trying to do suppression?
So this is what I'm most concerned about, because, we had countries that were elimination zones for a really, really long period of time. I mean, the UK actually said they weren't going for elimination because they were absolutely sure that countries, who were kind of suppressing infection in March last year would have a second wave, but they never did, But now we've had more and more transmissible variants, more and more severe variants emerge. I mean, the current variant, Delta, we think has basic reproduction number of 6. That means if there was a susceptible population, each person would infect 6 other people, compared to the original virus where this number was 3. And that's a huge difference. And the way that elimination zones essentially work is, one, by preventing cases coming in by very good managed quarantine systems, and 2, by when cases do slip through that system, sometimes very quick surveillance to contain those outbreaks before they spread widely into the community. Now, there are 2 problems now, because we've had, unfortunately, even countries like Vietnam and other countries who started sort of relaxing border restrictions on the basis of vaccination, which is not a strategy that's based in scientific evidence, because we know that people who are infected can get infected, who are vaccinated, doubly vaccinated, can still get infected with the Delta variant, potentially in quite high numbers, and pass it on, which is essentially what outbreaks in, for example, Singapore with the Delta variant were linked to, and possibly even in Israel. And the second thing is, when they do get into the community now, it's very hard to contain this because it's highly transmissible. So to prevent it entering the community once it enters the country becomes harder and harder with more transmissible variants. And that's what we're seeing, for example, in Vietnam and Australia, who have had elimination for long periods of time, but are now really struggling to get on top of community transmission. And I think that it's going to get harder and harder for elimination zones to maintain elimination because of the actions of other countries that have spawned highly transmissible variants. Because at some point in time, it's very hard to prevent highly transmissible variants spreading into the community, even with the best surveillance systems. And sadly, I think that's what we're seeing in many countries now. So it's the actions of countries that keep talking about living with the virus that are very sadly now impacting many zero COVID countries that have managed to protect public health and economy, who also very unfortunately have lower rates of vaccination and are now going to struggle with the impact of essentially the reckless strategies that other countries have adopted. And I think elimination is not the same as it was in March last year. I think it was much easier to achieve elimination at that point in time than it is now. And I worry that with every new variant that arises, it's going to get harder and harder and harder. And at some point in time, elimination is going to become impossible. So, it's not the same now as it was before. And I think countries need to pivot to elimination in a global manner urgently, because this idea of living with the virus is going to essentially have mass impact at population level. And to think that we can do this next year or the year after is simply not true. We either do it now or it becomes impossible at some point in time.
Yeah. And I have to add, I'm really concerned about countries that are much more poor. After watching what's happened in India and South Africa, a friend of mine told me that she lost 4 cousins in the last 2 months in South Africa. They were in their 50s, I believe. And I know a lot about Vietnam because I have relatives there, and their medical care is good, but very limited. And so if it really spreads seriously, they've already had examples, I'm told personally, where they have had elderly people that have been kept out of the hospitals because they're full in certain wards in the city of Saigon. And so, I mean, this is, and their spread is much less than what ours has been. So what happens if it really takes off in these poor countries? Those are just some examples. I mean, we're looking at a decimation that is just, out of some bad novels. So, I mean, we all worry about ourselves and our own countries, but I'm happy you focused on the world, because we're in this together. Unless we want to shut down travel entirely, which will never happen. The world is a connected place, and we have to do it.
What I found very concerning over the past year is the infiltration of ideology into science, into our scientific community. And there are clearly members of our scientific community who are following an ideological narrative and agenda rather than the evidence. And I'm really, really concerned by scientists in the UK and now in Denmark speaking about, for example, infecting children with the virus rather than vaccinating them, suggesting that it's good for SARS-CoV-2 to infect many children, become a childhood disease. This is extremely reckless, unethical, and ideological, and it ignores all the evidence that we have on the impacts of children from this disease, which we know are long-term in a significant proportion. We know that 7 to 8% of children go on and have long-term impacts, including neurological impacts that last for 12 weeks or more. In the UK, for example, we have 33,000 children with long COVID. of whom 9,000 have had symptoms for more than a year, to suggest that it's okay and even desirable to essentially expose these children to a virus whose long-term impacts are not even known and we don't know how to treat, rather than give them safe and effective vaccines that have been given to over 9 million children in the US alone, is frankly completely negligent and unethical. And I think that scientists who are promoting those agendas should be held accountable.